Good morning, friends. We are on to our second session of Dr. Sahasranam's ECG quiz. I hope you found the last session interesting and all of you made the diagnosis correctly. I would like to remind you again that you should revise the sessions of the ECG classes before attempting the quiz so that you recognize the patterns very easily. I'm sure all of you have revised your lessons. Today, I have lined up 3 ECGs as before. One is a rhythm strip of an arrhythmia and the other two are 12-lead ECGs. So let us go to the quiz straight away. Before that, I would like to remind you that the ECGs will be shown for a period of about 2 minutes or 2.5 minutes, during which you will have to interpret this and write down your diagnosis and answer any clinical questions which I ask. Following this, I will be discussing the ECG as I did in my previous classes. Now this is the first ECG. Now this is a rhythm strip of lead V1, right? It shows an arrhythmia, obviously. It's a rhythm strip. So what is the arrhythmia is my first question. My second question is, what are the clinical conditions where this can occur? And the third question is what is the ideal treatment of this arrhythmia in an acute setting? You get this arrhythmia in a patient acutely. What will be your treatment? Okay, folks, now you can start writing. Maybe 2 minutes or 2.5 minutes, right? So folks, I hope you have already interpreted the ECG and answered my 3 questions. What is the arrhythmia? What is the clinical condition where this occurs? Or what are the multiple conditions where this can occur? And what is the ideal treatment you will give if this is an acute setting? So we'll go on to the answers. You can see that the P waves are marked by red arrows here. I have marked the P waves and you can see that they are closely crowded together. And if you look at the PP interval, it is around 5 small divisions, 5 millimeters. When it is 5 millimeter, the rate will be 300 per minute. If you remember, 1500, isn't it? By the RR interval. 1500 divided by 5, which will give you 300 per minute, which is the P wave rate. Now, if this is the P wave rate, what is the P wave which comes at a rate of 300 per minute? Obviously, the answer will be atrial flutter, a regular P wave supraventricular tachycardia occurring at a rate of 300 per minute. Now you can see that the QRS is not coming regularly. There is an irregularity in the QRS. Hence, we would call it an atrial flutter with a variable conduction ratio, isn't it? So that will be the diagnosis, an atrial flutter with a variable conduction ratio. Now the next question is, what are the causes of this condition? Multiple causes are there. In India, the common cause we have always found is a rheumatic heart disease. Of course, nowadays rheumatic heart disease is not that obvious. It is less in incidence in some parts. The other condition could be systemic hypertension, cardiomyopathies, ischemic heart diseases, valvular heart diseases, old age. Anybody more than 70 years are highly prone for supraventricular arrhythmias. It could be atrial flutter or atrial fibrillation. Sometimes atrial flutter leads on to atrial fibrillation later on. Another important is post-cardiac surgery. After cardiac surgery, especially when the atrium has been cut open for intracardiac surgery, one can get such arrhythmias. So these are some of the conditions. There are more conditions. You can refer to any textbook and get them. Now the third question was, what is the ideal treatment if this is an acute condition? For example, you find it in a setting of myocardial infarction or in a setting of post-cardiac surgery, right? Then what will you do? We'll come to the next. So this was our diagnosis, atrial flutter with a variable conduction. And this was the findings, that is, you get a sawtooth appearance to the atrial P waves. You can see these are the sawtooth appearances which you get, which will be more classical if I had shown you lead 2 or lead AVF or lead 3. More seen better in that. In V1 you may not get the classical sawtooth appearance, and you can see ventricular complexes are irregular. Now the acute treatment of atrial flutter, it depends on the clinical presentation, isn't it? So if the patient is having an hemodynamic impairment, BP is low, patient is sweating, right? In that case, you will have to take a quick decision and a need for prompt restoration of sinus rhythm. You will do a DC conversion, isn't it? A synchronized DC conversion using about 50 joules, isn't it? That much is enough for atria. Now, if you want an elective restoration, patient is stable, so you want an elective restoration of the sinus rhythm, you can use anti-arrhythmic drug treatment. The drugs which can be used are butyllide, flecainide, propafenone, or class 1C agents. These are the class 1C agents. DC conversion also can be done. The only disadvantage of DC conversion is you have to plan it, and during DC conversion you have to anesthetize the patient. An anesthetist is ideally present because sudden endotracheal intubation etc. may be needed sometimes. The simplest anesthetic we give is a midazolam injection, where the patient is transiently anesthetized and quickly comes out of it, right? Or if it is in the setting of, say, cardiac surgery or in the cath lab while a catheter process is going on, you can resort to rapid atrial pacing also. That also can quickly convert the arrhythmia to sinus rhythm. Now, what happens sometimes when you give one of these drugs, the arrhythmia may be converted from 300, say, atrial flutter of 300 to atrial flutter of 200. And if it becomes atrial flutter of 200, suddenly the conduction ratio, here it was variable, conduction ratio may increase to 1:1 conduction. So the heart rate suddenly jumps up to 200. Now to prevent this, if you are doing it electively with drugs, what you can do is you can use one of these drugs, verapamil, diltiazem, esmolol, right? especially when you are going to use one of these agents. So initially you give verapamil, diltiazem or esmolol, which will act on the AV node and prevent a sudden increase, that is a one-to-one conduction is prevented. And then you follow it up with one of these anti-arrhythmic agents, which will help you to control the atrial flutter. Right? I hope you got the point there. So initially you prime the patient with verapamil, diltiazem or esmolol, which is an ultra short acting beta blocker, to reduce the conduction ratio or to prevent a 1:1 conduction when you give the anti-arrhythmic agent afterwards. This you can do. Now we'll go on to the next slide. So friends, this is the next ECG of a 56-year-old man who was brought to the emergency with a stroke. What is the ECG diagnosis? The next question is, what could be the QRS axis in this patient? And the third question would be the cause for his stroke. What caused his stroke? So once again, what is the diagnosis of the ECG? What would be the QRS axis to be calculated from the limb leads? And what could be the cause of his stroke? Kindly answer this and we'll get back to you. So folks, I am sure that you would have answered this. We'll go on to the answers to this question. So you can see this slide here. The limb lead shows Q waves in 1, Q wave here, 2, lead 3, AVL and AVF, isn't it? So there is an extensive presence of Q waves here. Also, you can show the chest leads, though shows an inverted P, even though it doesn't qualify to be called a left atrial enlargement. Okay, we'll leave it. And the R waves in V1 is of 8 millimeter. Look at this R wave. It's about 7 to 8 millimeters in height. There is no S wave at all in V1. Okay, that is a point worth noting. The other thing is, if you look at the chest leads, what do you see here? You see an ST elevation with Q waves, isn't it? Small Q waves here. ST elevation in leads V2, V3 V4 and V5. V6, of course, Q is there. Sorry, the picture is obscuring that. Whatever, right? So what does it show? This shows that the Q waves in the limb leads, what do they denote? Without an ST elevation and T inversion, they denote an old infarction, isn't it? And where is the old infarction? The old infarction is in 2, 3 AVF, right? So inferior wall. In addition, one is showing it as well as AVF, so lateral wall. And there is an R wave in V1, so posterior wall. So it is an infero-latero-posterior or infero-posterior-lateral wall myocardial infarction, which is old because the Q waves are only present. Now, what does the anterior wall show? There is an acute anterior wall infarction, isn't it? Actually, this is in almost a hyperacute stage. The patient came with a stroke, but he never complained of chest pain. Maybe either he couldn't complain because of the aphasia, or the patient, the stroke was more prominent and this was a silent infarction. Whatever be it, this is an acute infarction. So the diagnosis here will be limb lead shows Q waves in 1, 2, 3, AVR, AVR is not there, AVL, AVF, isn't it? Chest lead show an inverted P in lead 1, which is not significant. R wave in V1 of 8 millimeter and ST elevation in all this, right? So the diagnosis would be acute anterior wall MI, old inferior wall MI with posterior wall MI and lateral wall MI, right? Now, what is the QRS axis? Here, if you look very carefully of all this, it looks as if AVL is the one which is equiphasic, isn't it? AVL, what is the axis of AVL? It is minus 30, isn't it? The normal axis of AVL is minus 30. So minus 30 plus 90, and since all these are negative and AVR is positive, look at AVR, it is positive. So that means the axis is going quite to the extreme left axis, or you can even call it extreme right axis. That is minus 30 plus another 90 will make it minus 120 degrees. So the axis will be something what you call as northwest axis towards the right shoulder. So that will be the axis in this patient. That is an extreme left axis deviation or an extreme right axis, whichever you call it. Now, what could be the cause of the stroke in this patient? The previous myocardial infarction scar was there, isn't it? This is an old infarction having a scar there. Whenever there is a scar of long standing, it can produce a clot there. This clot could have been discharged and it could have produced an acute infarction, isn't it? Well, this could have occurred during the episode of current infarction. Sometimes what happens during an acute infarction, there is a transient arrhythmia which may occur. It could be a transient ventricular tachycardia or even a transient atrial fibrillation or anything, which might have occurred in the patient's home. By the time he came to the hospital, again he was in sinus rhythm. During this arrhythmia, that clot could have been dislodged and produced a stroke. That is one possibility. The other possibility is when there is an acute anterior wall myocardial infarction, he could have had a severe hypotension, a transient hypotension while he was at home. And that could have produced a thrombosis of the cerebral artery, causing a cerebral infarction, isn't it? Both of these could be causes of strokes. There could be other minor causes also, which I am not elaborating here. Now we'll go to the other ECG. Now this is an ECG of a 70-year-old man who came walking to the cardiology outpatient clinic with a history of recurrent chest pain occurring for the past 3 days. Now when he came to the OP, he was not having any chest pain. He was free of chest pain. Okay. And at the time of examination and at the time of taking the ECG also, he was free of chest pain. So my question is, 1, what is the diagnosis of his condition? Second, what could be causing this type of ECG change, which you are seeing in the ECG? And third, what will you do for the patient? So I think these 3 questions, what is the diagnosis of this condition? What is causing this type of ECG change? And what will you do for the patient? So you can start. So friends, I'm sure you would have answered all the questions correctly. We'll go on to the answers. So what do you see here? The main finding is the presence of, this is the striking feature here, isn't it? Deep and symmetrical T waves, the so-called arrowhead type of T waves, inverted. In lead, it's present in lead 1, 2, AVL, AVF in limb leads, as well as lead V2 to V6 in the chest leads. What is this called? This is called Wellens syndrome type B. Type A is biphasic waves and type B is deep inverted T waves. You remember that the patient comes with recurrent chest pain and the ECG changes persist even when the patient is free of chest pain. It's a classical description in this patient. Now, what is it due to? It is due to occlusion of the proximal left anterior descending artery. We have discussed this in some, I think it was in the miscellaneous class towards the end of our ECG session. And the third question was, what will you do for the patient? You will immediately subject this patient to an urgent coronary angiography to relieve the block in the left anterior descending artery. I'm sure all of you would have got these answers correct. So with this, I think, this was the findings. Deep symmetrical T waves in limb leads, deep symmetrical T inversions in chest leads, preserved R wave progression. That is a point which is favor, and the absence of Q waves also. So R wave is present and Q waves are absent, and no ST segment elevation of significance. These are the features of Wellens syndrome. So this is due to a critical stenosis of the proximal left anterior descending artery. Intermittent periods of pain, free intervals are there, right? So friends, I hope you have successfully diagnosed all these 3 ECGs, and I am sure you would have revised your classes before this. For any clarification or comments, you can contact me through the email or put a comment below, which I will be glad to answer. Please share these classes with your friends and colleagues and subscribe to my channel. If you want any of your friends to be included in the ECG WhatsApp group which I am having, you can send me their name and phone WhatsApp number. I will include them also. Even today I got somebody's name which I have included. And meanwhile, bye and thank you. Within 2 days, I will be meeting you with another new episode of ECG Quiz. Bye friends. Thank you.